really try to crunch a lot of medical in a very short time span. A lot of different topics here that we wanted to try to address, so we'll try to run through it pretty quick. But this is just running and walking, everything medical. And a lot of the things I'm going to talk about are running and walking specific. Some of the studies that I will quote will be specific to running. So if I use the word runner, I'm not trying to say hey, everybody here is a runner. I understand that we have a lot of walkers in the group, and but when I say something specific to running, it's usually specific because that's what the studies show. But what we do find when we look at a lot of the literature, and my experience is we're seeing the same injury patterns, same type of things, whether it's runner or walker. So we can really utilize those words almost interchangeably through a lot of this talk. But I'll try to make that point of emphasis when it is something unique just to runners. So for overview, I just want to talk briefly about epidemiology. Just look at some numbers, talk about emergency preparedness, what we need to think about when we're out on the trail with our participants. Look at running and walking shoes and how that's an important part of our equipment and what we should be counseling our participants about. Look at the minimalist running and walking shoes. I think that's going to be an important part. We're seeing that really swinging it swung really far the other way. I think it's swinging back a little bit, but there's still a lot of interest in that. And then briefly talk about common running injuries. And then if I think once we get through that, everybody stays in the Holiday Inn Express, we should be able to treat everybody on Saturday mornings. So that's Verrazano Bridge. If you guys haven't had an opportunity to do New York City Marathon, just an amazing experience. You literally feel the bridge shake as you're running over it. Not to mention all the elbows that are flying going across that bridge. It's an interesting experience. 50 million runners, and this is the running specific data, 50 million runners in the United States, makes it the #1 sport in the United States, contrary to ESPN, stuff like that. 625 marathons in 2010. And that's a significant increase from where it was before. Columbus, 24th largest. There are 507,000 people that finished marathons in 2010, which was a significant increase from the year before, almost a 8.6% increase from 2009. About 60-40 male-female when we look at marathon distance. When we look at the half marathon distance, it's almost the exact opposite, about 40% male, 60% female. And that's a pattern that we've seen maintain itself through quite a few years now. Gender differences, average male finisher was 40, average female finisher was 36, and those are the average marathon times. So just some numbers, sometimes people ask about it, marathons, how big is Columbus, stuff like that. We can say 500,000 people finished a marathon last year. When we look at running and injuries, anywhere from a third to a half of all, and this is running specific data, a third to a half of all runners will become injured each year. Anywhere from 20 to 70% will seek medical attention, just depends on how severe the injury is. And when we look at that data, there's certain patterns that jumped out of that literature as risk factors. And one of them was the miles per week that you're running, somewhere around 35 miles per week. Once you get above that, there's a significant increased risk of injury, and that's exponential as you kind of get closer to that 100-mile range. Previous injury, if you've had an injury in the past, that's going to predispose you to an injury in the future. I think something that we can counsel people on is if they have an injury and they didn't really get it addressed, let's make sure they get it addressed because that has a way to come back and haunt people. Oftentimes just we didn't adequately rehabilitate that injury to begin with. Novice runners, that was something somebody new to the sport over the last 12 months. The only thing we can suggest with people is, like Steve said, we want to make sure they enjoy this and they come back again, and then they won't be novice much longer. And training intensity, that's another big one. If you're training hard all the time, like Steve was talking about the never land of training, we're going to see an increased risk of injury. We got to make sure we're doing our recovery days, our active recovery, stuff like that. So let's talk about emergency preparedness. Key points I want to hit, there are a lot of life-threatening emergencies out there. We can't really prepare for all of them, but we can have a general plan in place. And we want to make sure that we have that plan. We think about contingencies and stuff like that. But fortunately, these events are pretty rare. Historically, we've always quoted somewhere around 1 in 50,000 people at a marathon event is probably going to have a sudden cardiac event. Some newer literature I just sent out earlier this month that those numbers are actually changing now with the increased participation numbers, stuff like that. Somewhere around about 1 in, I think it was 187,000. So there are lots of different numbers out there right now. But the reality is these are pretty rare events. But we need to think about them. We need to be prepared for it. We need to have a communication plan that Jeff kind of highlighted, what we're going to do if we get in that type of a situation. So the first thing, do you have a plan? Think about, what are you going to do? If you're in a group, somebody goes down, who's going to call? You have your phone, who's going to manage the injury, who's going to call, who's going to get that special attention. Make sure you have your phone accessible. As Jeff kind of mentioned, make sure we have kind of a waterproof bag that's going to, protect it from sweat and stuff like that, and a way for you to carry your phone with you. Make sure you have those emergency numbers available, and whenever there's any question, 911 first is always my line. And then let me know about it. Let Jeff know about it, something like that. That's what I do. Race day, when I'm the medical director for race, I tell all my volunteers, 911 first, then let me know. And it's the same thing as it comes to Jeff. If somebody needs a special attention, let's get the people there that can take care of them appropriately, and then let the cavalry know. First aid supplies, we talked about the Mylars. It's kind of hard to carry a lot of that stuff out there with you. But if you want to throw in a couple, Band-Aids or something like that, might be something simple to throw in with that Mylar. Just, having potentially just a couple extra supplies with you might help. And then the other thing, not quite as applicable to us, but, EMS response time is going to vary in terms of what your plan is. And you may think about, hey, we're all planning for what happens, here, on the trails or the banks of the Olentangy. But what happens if maybe you're, at a race, and you're the one who kind of sees a participant go down? You're an extension of the medical team when it comes out there on race day. What if you're out on an ultra race or you're doing a trail run at Alum Creek? All those things are going to maybe vary, and you always have to think about that. What's your response time? Maybe you're going to be responsible for doing a little bit more medical care than you would think, just because it might take 10 minutes for an EMS team to get there. And those are all things you might just want to consider depending on where you're participating. Once you have an injury, what do you want to do? Well, the first thing is, I learned this as an intern in the hospitals, you don't want to sprint up the stairs as quick as you can, run all the way down the hallway, and then get to the room and you're useless because you can't even talk, you're trying to catch your breath. Take a minute, collect yourself, relax yourself, because if you're running, just try to get to this, you're not going to think as well, and you want to think clearly. So don't panic. Just try to think calmly, talk calmly. The way you talk and communicate is going to be contagious to others. If you're really anxious and you're spreading, kind of a little bit of anxiety around, everybody else is going to get pretty anxious too. We want to try to, diffuse the situation, try to keep everybody calm, and that's contagious as well. If you kind of talk in a calming voice to people around, I want you to go do this, I'm going to do this, and kind of direct people. And so don't rush. And then the body position. Now we need to look at, think about the participant. What the position are they in? Is it safe to, roll them over and transport them and stuff like that? So those are things that you want to do once the injury happens. So, in terms of evaluation of the fallen athlete, I'm not going to go into a whole lot of details because a lot of this, we kind of hit in the CPR class. But, mental status, are they awake? It's the first, are you okay? Are you okay? If they respond, we're doing well. That's a good day. If they don't respond, now we have to start about, when I was, trained, it was always ABCs. Now there's a big emphasis on CABs. We really want to focus a lot on circulation and compression. They talk about now the no hands CPR even, or the hands-only CPR, where it's only compressions, talking about 600 cycles of compressions before we even look at the airway. So, that's, I want you guys to do what you were trained in, but that's some of the big movements right now. We're really focusing a lot on compression. So it's look for circulation. Then we're going to look at airway, breathing, stuff like that. And once we know they're responsive, they have proper circulation. Now let's assess for other injuries. Let's look at their head and neck. Did they injure themselves perhaps when they went down, and do we need to immobilize them so that they're not going to hurt their neck? Let's look at their chest. Is there any trauma there? Abdomen. Then kind of look at the skin and stuff like that. But that's kind of the order you want to go through when you're kind of assessing an emergency situation. Circulation. Again. Activate EMS. We know the best outcomes come from how quickly we can get an AED to somebody. And if we're on the banks of the Olentangy and we're doing compressions, all we're doing is just trying to preserve oxygen until we can get that AED on a participant. So when it comes to a sudden event, that's the same thing true in outside, on in a race situation, stuff like that. It's all about getting the AEDs there. If they're unresponsive, obviously we're going to do CPR. It's that 30 to 2 compression cycle and continue CPR until help arrives. So that's, I think what everybody's kind of learned here. Information to provide the EMS, if you're going to call 911, I remember just recently I called 911 and the lady said, "Sir, calm down." I'm like, "I am calm," but, again, we want to be calm. There's certain things we want to tell them, and, the suspected injury, what do you think's going on? This is what I think's going on. This is the condition of the participant right now. What assistance is being provided? Is somebody doing compressions, or is this person breathing and responding appropriately? And then what's the exact location? And that's sometimes the hardest thing to give. Be aware of yourself on the trail. Know where you are. Are you at the corner of 161 and 315? Or know those streets pretty well as you're kind of going across them, so that if you're in that situation, you know how to get somebody there. So again, key points, many life-threatening injuries out there, but fortunately they're pretty rare. And the biggest thing is we want to make sure we prepare properly for it, and we want to have a communication plan. Because my experience is when it comes to saving lives, it comes down to how efficient is your communication and how quickly can you get people to where they need to be. We've been kind of unfortunate, I'd say, in the last year. We've had 2 events, one at Cap City, one at Columbus. They're full cardiac arrests, but they're both resuscitated, fully and, left the hospital, and are actually back to running. And a lot of that had to do with communication. We've really focused a lot on our communication plan, and that's one of the key things that we want to focus on in our group, making sure we're communicating appropriately. So in terms of running and walking shoes, big key points I want to hit is let's recommend our participants get a professional shoe fit. Let's make sure that we're doing them that service, because I see so many people coming in that just haven't really done that. And you look at the shoes and you're like, really? That's what you're running or walking in? I think we hit it hard, but, I don't know if maybe, Jeff and Tim don't want to hit it too hard because, the conflict there, but I think that's our job. We see these people, we see what they're running and walking in, we see that they've worn down and stuff like that, so let's make that recommendation. Very good literature out there showing that we probably need to change shoes about every 350 to 500 miles. And there's some new literature out showing that cushion insoles can help to prevent your risk of stress fractures. So in terms of running, walking shoes, do want to hit on that life expectancy that I just mentioned, talk about just that proper fit. This is that study I was talking about where we look at running and walking shoes. We know somewhere around 250 to 500 miles, you lose at least 40% of your shock absorbing capacity. Every time your foot strikes the ground, 4 to 5 times your body weight has to be absorbed by the body. And the first place it goes, if your shoes aren't doing it, are your knees, your shins, and your bones. And those are the injuries that we're going to see later on if your shoes aren't doing what they should be doing. I just saw somebody today who goes, I really don't feel like I need to replace my shoes. I'm getting 1,000, maybe 1,500 miles on them. No, that's why you're in the office seeing me right now. I mean, you may not feel it, but you need it, okay? So let's make sure we're making those recommendations to people. Just, different types of foot type. We have different types. We have overpronators. We have underpronators. We have that neutral arch. This is what they do at Fleet Feet. This is what they do well. The neutral cushion shoe, this is for that more neutral type person where it's very cushioned in the insole right there. There's nothing hard preventing you from overpronating, whereas you have an adrenaline here where you have that higher density, harder density that prevents that shoe from collapsing in. That's the whole concept of shoes. I think people are pretty familiar with that. I don't want to be a shoe expert. We're not shoe experts. Let's make sure we're getting them to the right people here. This is a cushion insoles. I didn't used to have this in my talks, but recently a study came out showing that something like a Superfeet, just an over-the-counter insert, can help prevent your risk for stress injury. So I started to recommend that to people. Maybe not everybody, but certainly can't hurt. But at the same time, maybe someone who's had a stress fracture in the past, or they've had problems with this. Hey, have you thought about that? That might be something to look at. That's a good question. I mean, I typically think about a Superfeet maybe lasting 6 months to 12 months. I don't know. What do you guys typically think of for that? Okay. Yeah. So 2 pairs of shoes.
How do these compare to the $300 orthotics that?
Yeah, I think they serve different purposes. The custom orthotic is more we're trying to treat something perhaps that's biomechanically going on. And I've heard some people say that maybe a third of the people that maybe need an orthotic would benefit from an over-the-counter one. The other people maybe need more of a custom one. But this literature is more just derived at just all comers looking at trying to decrease risk for stress injury. But certainly I wouldn't say if somebody has custom orthotics, I'll throw them out, just get some Superfeet. Perhaps we're treating something medically there that needs that custom orthotic. Okay. So key points again, let's recommend a proper shoe fit. Let's think about shoe life, 350, 500 miles, and then think about those cushion inserts, maybe decreasing our risk for stress injuries. In terms of the minimalist running, very, very hot topic right now and continues to be. Discussions going on at every level with this and, continuing on. But what are the key points? Well, when we look at minimalist running, some of the thoughts are less joint impact, may prevent injuries, stronger feet calf muscles, increased injury risk during the transition, and then the important thing is a slow transition. So let's talk about that. When we look at the theory, what's the theory behind, someone, it's maybe mainly Christopher McDougall, he's the one who created the theory with Born to Run, and it's that the modern running form is incorrect. Okay, so we, as a runner, that heel strike mechanism that we've adapted to is incorrect. That is not the way you're supposed to run. And it's because of advances in running shoes being more cushioned, it allowed people to change their gait and do more heel strike because they can absorb some of those shock, that shock force because of the shoes. And so it changed our gait over time. And as a result, that's created more impact forces. And I'll show you a slide in just a second in terms of what I mean by impact forces. But then they also argue that running shoes, although they've allowed us to change our gait, they haven't changed injury patterns. And if anything, they've increased the risk of injuries because of that increased impact. And that's going to lead to injuries. They've also argued that you're going to get decreased performance because you have these heavier, bulkier shoes. And there's some very good physiologic studies showing that if you wear, heavier weights on around your ankles, you're not going to be as efficient. And so that's another concept that, the minimalist shoe is going to be more efficient. Decreased sensory feedback because you have these big, shoes all over your feet. You're not going to necessarily feel the ground. You're not going to feel changes in the terrain and stuff like that. And then that's going to inhibit that natural motion that ultimately may lead to some of the weakness in the ankles or the muscles around the ankle and foot. Conversely, we got to understand though that our running environment has changed. When I think about the banks of the Olentangy, I don't think about what Christopher McDougall was talking about, the tribe that he was describing, that are going through mountains and passes and dirt passes. This is perhaps maybe what people think of a minimalist runner, but that's not what I see every day when I'm running on a straightaway of the banks of the Olentangy on a nice paved asphalt surface. So we got to factor that in, and really, how is that going to play a role? Decreased change in elevation. We don't have a lot of elevation change where we run. Whereas you can imagine these people probably had a little bit of elevation change over the last quarter of a mile, let alone over the 20-mile run. Fewer turns, that's going to affect gait and mechanics, and then also consistent pacing. Now, we just harped on it. We want consistent pacing. Whereas you looked at maybe some of the more historical running tribes, they were changing their gait and pace a lot. And that's going to have a factor when we look at some of these injury patterns. This is more kind of what we're looking at from a modern day running. I think that looks like the start of Grandma's Marathon almost, just a straightaway shot. But here we're talking about the impact forces. So when your foot strikes the ground, these are the forces and body weight. Kind of right here, this peak right here is the whole concept of the minimalist running impact forces of someone wearing running shoes versus not wearing running shoes. And so someone in running shoes has this big peak right here, whereas if you are in a 4-foot runner minimalist approach, you don't see that spike right at the beginning. You still have the same gait pattern, in terms of later on in that phase you're going to get impact forces, but not that initial spike. And so that's the whole concept of lowering these impact forces. So what are the pros of minimalist running? Well, the theories. Well, again, better biomechanics. You're going to be more efficient, less joint impact, may prevent injuries. And that's been one of the biggest debates. And Steve and I get in this discussion quite a bit ourselves. There isn't a lot of data out there on injury prevention. All they have are impact forces. And no one's been able to say impact forces mean injuries. Just because we have that impact force doesn't actually mean we're going to increase our risk for injuries. There was a study that did just come out in the last month, a very, very small study, that suggested that there was decreased risk of injury because of the impact forces. And so I think we may see more studies coming out, and we're going to have to continue to evaluate this. But, you're going to have stronger feet and calf muscles because of this. Less eco-footprint. If you're running barefoot, you're not going to have a lot of, stuff you have to worry about biodegrading and, trash dumps and stuff like that. Cons of minimalist running. Well, perhaps some new injuries, and this is something I'm seeing a ton of in the office. People who just make the transition, coming in with stress fractures in the feet, coming in with Achilles tendon problems, coming in with calf problems. And that's because we're making this transition maybe a little too quickly. Less choice of running shoes. You know, we don't have as many options out there when we're looking at Minimalist, but that's changing. You know, we're seeing a huge swing in the manufacturers trying to catch up very quickly with the industry. Foot damage, you know, I mean, as a medical director, I see people come in the medical tent that tried to run barefoot, and now they have a laceration on their foot. So those are things we have to contend with. Sore feet from the hard surfaces, you know, those are the other thing that we'll get, just kind of aching pain, stuff like that. I think one of the key things is if someone is going to make that transition, first of all, we have to ask them why. And if they've thought through it, they have a good reason, and they want to make that transition, I think the key thing is it needs to be slow, slow, slow transition. And that's where most people I see are getting into trouble with. Start with just walking barefoot. You know, walk around the house a little. How many people walk around the house barefoot? You know, if we want to get minimalist, just do that at home. You know, walk around your house. Try jog in the grass or track. A lot of track coaches will do that. They'll have their kids go barefoot up and down, and they're trying to decrease, strengthen those muscles, decrease the risk of shin splints and stuff like that. Still need that professional fit. We need to recommend those people go to people who understand the industry. They understand the transitions they need to make. A lot of these people are just kind of, hey, I'm just going to do this, and they're doing it on their own. At least we're getting them another encounter with somebody who has some information that can help them. So let's still recommend them for a good fit. And then, practice good form. Let's help them with their running style. Stand upright, shorten their stride. And that's one of the other things I see is a lot of people are making this transition to the new shoes, but they're not changing their gait. They're still heel striking. And these shoes are not made for heel striking. There's no cushion there. Talk about impact forces. You're going to see a huge spike if you're trying to use a minimalist shoe and not change your gait. So that's one of the other big things that goes along with it. And again, just want to be slow with it. There's some transition programs out there. So again, key points, less impact forces, may prevent injuries, stronger feet and calf muscles, increased risk of injury during the transition, so let's recommend slow transition.
With the minimalist shoes, the construction that is, and the materials that are used, would you be replacing them more often?
I haven't seen that. I don't know what you guys' experience is, because I think, more going out over that, they're changing their gait, they're kind of doing more ball striking. They're really absorbing a lot of those forces through their calf muscles and muscles of the ankle and foot, so I don't see that they're wearing down. It's going to depend on the surface you're running on, though, and stuff like that, I'd imagine.
Yeah, the manufacturer's recommendation is roughly the same. You don't have the material that you're compressing in some of the shoes. It depends on the minimal shoe you're going with. The minimal shoe basically means less drop from heel to toe. Your average shoe has 12 millimeters from the height of the heel to the height of the forefoot. There's zero drop shoes, meaning a truly minimal shoe that still have EVA, so that foam. Those shoes are going to break down a lot quicker in terms of their shock attenuation than like the Vibram or the New Balance Minimalist. It's just the rubber. It's like wearing a tire on your shoe. Just like a training shoe. If you wait for the rubber to be broken down, the shoe's already broken. The shoe's already well past its lifetime. So.
And I think that's, again, this industry is changing throughout the whole year. I mean, we're seeing new models come out, and that's why we want to recommend that professional fit, so that they're getting that information, because it's going to change based off the shoe and stuff like that. So let's continue to recommend that. In terms of common running, walking injuries, going to fly through these pretty quickly. Just a couple ones I want to hit. These are the most common ones. They're on your slide there. The 10 most common running injuries. Number one is patellofemoral syndrome. That is runner's knee. And then we have shin splints, and then we kind of go on down. But you'll see stress fracture pretty high up on there, 7.2% of all running injuries. Another study I saw recently, 15% of all running injuries. So that's something we always have to keep in mind if people coming in complaining of some focal bony pain. So what are the key points? Well, knee pain is the most common running, walking injury. Patellofemoral syndrome is the most common with that, about 50%. Then we have IT band syndrome. I want to talk briefly about stress fractures. Look up someone talking about unilateral pain. It's very focal, one spot on the bone. That's what we want to think about. Other thing we need to caution is anybody coming in with anterior hip pain. That could be potentially a stress fracture. Stress fractures in the hip, a little different than the shin. Shin bone will be very focal. It's pretty obvious. They say it hurts right here. Whereas a hip stress fracture, you know, man, my hip's just really been hurting in here. And that's a very high-risk stress fracture we always need to think about. A little bit more difficult to diagnose. So something, and we'll talk through that in a second. And then black toenails. Just want to hit on that just for a second. This is the knee joint. This is looking at the undersurface of the kneecap. This is the problem where runner's knee comes. It sits in a groove at the end of the thigh bone, the kneecap does. And the kneecap is attached to the undersurface of the quadriceps muscles. So the quadriceps muscles control the movement of the kneecap. That's the key thing when we talk about runner's knee. When we look at epidemiology, it's more common in females. It's about 25% of athletes, you know, all comers, just not injured. 25% of athletes will have some element of runner's knee going on. When we look at patellofemoral forces, so that's the knee joint, the joint between the kneecap and the thigh bone. When you walk, about half of your body weight, that force is generated through that joint. When you do a squat, it's 6 times your body weight. So a lot of these people will complain of pain squatting, kneeling, going up and down stairs because of the increased forces in that patellofemoral joint.
Where's the meniscus in that? Is it
meniscus is more on the side. So meniscus is going to be inside, outside, where this is going to be right on the front, anterior knee pain. So that undersurface of the kneecap just getting all raw, and they'll complain of pain right underneath the kneecap. So anterior knee pain, we always think kind of runner's knee. So that's going to be right on front, as opposed to cartilage. Usually that's going to need an injury. Don't see a lot of cartilage injuries in runners, and that's going to be on the joint lines. We'll talk about pain with stairs, theater signs. Some people complain of pain sitting for long periods of time, like trying to watch a movie or something like that. You know, my knee just gets stiff. You know, that's patellofemoral syndrome. Treatment, you know, if we diagnose it, it's going to be some special quadriceps strengthening exercises, rebalance those quadriceps muscles, work on some strengthening of the muscles up in the hip. And what we're trying to do is realign that kneecap so it starts gliding the way it's supposed to. The problem with this is people get an imbalance in those muscles and it starts dragging through that groove and it gets raw on the undersurface. So we need to realign those muscles. So this is kind of more physical therapy. Ice, relative rest. My usual line is, if you're not limping, I'm okay with you running. Get some ice on it. Do what you can do. Be cautious with those squats and lunges because that's going to aggravate it. And if you can't run right now, let's get on the bike, let's get on the elliptical, continue training because structurally the knee's okay. Second most common cause of knee pain, IT band syndrome. This is not runner's knee. A lot of people get these two confused. They think IT band is runner's knee. IT band is different. Runner's knee is the front of the knee. IT band is the outside of the knee. Okay, so lateral knee pain, pain on the outside of the knee, is more often IT band. Okay, and that is because your I is iliac, which is your hip bone. T is tibia, which is your shin bone. It's a big muscle that runs all the way along the outside of your thigh. It snaps back and forth over the end of your thigh bone every time you run and every time you flex and extend your knee. And eventually that IT band, as it runs from here all the way down, as it snaps over the bony prominences at the knee, or you can actually get IT band at the hip, because there's a bone there that snaps over, you'll get pain on the outside of the hip or the knee. Classically, it's going to be long-distance runners, but also cyclists will get this too. Very common in cycling. Bike fit's a big issue for cyclists if it's a cycling issue. People who have very tight IT bands will be an issue. Oop, what did I do? Okay, there we go. Mechanism of injury, usually going to be overuse, training errors. We want to counsel people, make sure they're not putting too many miles up too quickly. Hills will aggravate this. The first time I had IT band was when I was doing a trail run and a lot of downhills, and I got to the point where I could barely run the downhills. I almost had to stop, running, those hills. So it's very painful going down hills. So pain during or after long runs, classically this will shut somebody down. They'll be like, I was doing well, I got to mile 18, I just couldn't go. My knee locked. They'll say their knee locks on them. It's going to be that lateral pain shooting up the leg. Treatment, lots of ice. Ice, ice, ice. This is a bursitis, really. There's a bursitis component, so itis loves ice. So itis is inflammation. Let's get some ice on it. And then, again, physical therapy. This is where we need to focus a lot on IT band stretching. My experience is people focus too much on IT band stretching. That's an important part of this, but one of the bigger parts is probably some weakness in the hips that's causing that thigh bone to roll in too far and rub over the end of the thigh bone. So not only is it important we get the stretching going, which is what everybody knows about, they read in Runner's World, they get online, they know all the stretching exercises, but they're missing the strengthening. And those are some exercises we need to get people on.
Where do you want ice?
Right where it's painful. So if it's the outside of the knee, get it right over the knee. Yep, exactly. And then sometimes we have to do injections. We do injections. This is the one thing we will inject right before races to try to get people through. It's the one area that's actually pretty responsive to an injection to maybe get somebody, because usually this happens late in training. You know, last long run, they got 3 weeks out. Probably not going to have a lot of effect with strengthening and stretching and all that with 3 weeks to go, so we can try to inject it. So this is what I do the week before Columbus Marathon. We have about 15 of these, injections going. So stress fractures, this is the other one we need to think a lot about. Focal pain, so this is going to be one spot. Tibial, most common. Typically tibial stress fractures of shin bone, it's going to be right here, junction of the distal third of your tibia and the proximal third. So right here is the most common site, but you can get it anywhere on your tibia. Second metatarsal bone, so that's your foot bone. Second metatarsal bone is the most common one in the foot.
Is there swelling when there's a...
Sometimes you will have soft tissue swelling. Yep.
Something that was swelling, so you tell them.
Yep, so you can have swelling. So the things that always make me think stress fracture are, is it unilateral? Usually if it's bilateral, probably unlikely. But if it's unilateral, just one leg, one spot hurts. That's potentially a stress fracture. So something to start thinking about. So tibial stress fractures, here just in a little x-ray, you can see a little stress fracture right over there brewing. You'll get some thickening of the bone as it's trying to heal that area. And then as it gets a little bit further, you can start to see that line breaking through. And that's kind of a tibial stress fracture. Removal of offending force, everything with stress fractures, we want to bring them back gradually. So someone doesn't want to just say, hey, your stress fracture's healed. That's the one thing I unfortunately see is somebody will go somewhere, they're told they had a stress fracture. They said, just take 6 weeks off from running, then work back into it. So like any good runner, they take their 6 weeks off and then they go do their 20-mile long run the next day. And then they're right back where they started. So we want to be very gradual in how we get people back afterwards. Be very direct in that. Femoral neck stress fractures, this is what I was talking about. Very subtle. This will just be anterior hip pain. They'll just complain of pain kind of right in through there, more unilateral. Women more often than men. X-rays will frequently be negative. That's the problem with one of these, where you get an X-ray and it's negative. So this is something sometimes we need to do a bone scan for, or an MRI. And here's what we're talking about. Right through the neck is the concern of the thigh bone, the femur. You can get a stress fracture through there. The key thing is there are two types of these. Most people get the compression side, which is on the underside, the top one. And that's a good one because your body weight is actually pushing those two pieces of bone together. And so it's not going to separate. But if you get one on the top side, your body weight is pulling that apart. And that will fracture through completely. And unfortunately, if it does, it's not a good thing. And that ends up being a surgical problem. So, depending on where it is, here's some x-rays. It will just usually be, they'll just complain of pain right on the front, which, not to alarm people. I see a ton of, hip flexor strains and adductor strains and groin strains, but we just always have to think about it because I've seen a lot of people run through these and end up with some bad problems because if, you let it go too long, it does that, and that's the treatment. So we don't want that to happen. Okay? Runner's toes. Not a fun thing. This is an ultramarathoner's toes. Duct tape does work for everything, if anybody didn't tell you that. Subungual hematomas, a collection of fluid underneath the toenail, very painful, just through that repetitive microtrauma. And if you do get a black toenail, we can drain it. If we drain it quickly, it helps. If it's been going on for 2 or 3 weeks, it's probably not going to help too much. Draining sounds like a painful proposition, but it's not. It is very easily done. You just take a small little, it sounds bad, but just you drill through that nail. It requires no pressure on the nail, and it's immediate relief. Most people are kind of afraid to do that. They say, well, I'm going to get on Runner's World and see. And they said to do a hot paper clip. That is painful because you have to push it through the nail. You'd much rather drill through that thing. The only thing I put up there is just, in our world, we always have to think, well, what else could it be? This one will kill you. This is not toenail. This is melanoma. So all black toenails are not black toenails, So if they're not a runner or something think about that. But, I'm not saying, hey, I need to see every black toenail to make sure they don't have melanoma. Most marathoners are going to have that. But just, something we always think about. It's not...
Consistently, almost never having a toenail anymore because it's just not going to happen is okay.
Yep.
There's nothing
absolutely
horrible about it.
I think I have about 6 right now.
Okay.
So.
I'm never going to have certain toenails again.
Yep, and that's just part of it. And, proper shoe fit. I do recommend that a lot when it comes to runner's toes, so let's make sure we're doing those. Let's remind the guys about chafing. This is when I worked in the medical tent at the Chicago Marathon. Those are not racing stripes. So, let's make sure people know about Body Glide. Let's make sure they know about nip guards and Band-Aids. That's our job as coaches when we see people out there. So, key points, knee pain, most common cause of knee or pain, or most common injury in a runner. Anterior knee pain is almost always going to be runner's knee. Lateral knee pain is going to be IT band. Those two conditions make up 75% of all knee pain. So it's something to think about. Stress fractures, let's always think about that. And then black toenails and chafing. Let's be ready to help support our participants that way, because those are the joys of the rite of passage of running. So thank you. And that was a picture I took over the Verrazano Bridge. So now we're right back where we started.